This audio PowerPoint will cover diseases of immunodeficiency and cancer. Immune deficiencies occur when the immune system fails to recognize infectious agents, severe infections not suppressed or controlled. So there are congenital or genetic primary immune deficiencies, and there are also secondary or acquired immune deficiencies. Some of the warning signs that patients may have that may be an immune deficiency would be getting frequent infections, frequent ear infections, sinus infections, pneumonias, needing to be on antibiotics frequently, again, recurrent skin infections or abscesses, and osteomyelitis, cellulitis, any of those sorts of things. A family history of primary immune deficiencies might lead someone to want to investigate that a little bit more as well. So basically, if you think of somebody who is immunocompromised and has more of those serious infections and tends to get sick more frequently, they may actually have an alteration of their own primary immune system. The acquired immunodeficiency that we are going to talk about is HIV infection and AIDS. This, as we know, is a serious disease of the immune system and will result in death once it is end-stage AIDS diagnosis. This occurs when the CD4 T cell count falls below 200. Then they would diagnose it as AIDS and end-stage. Now, a normal T cell count is 500 to 1200. So less than 200 is end stage. We will talk more about the causes and how we can prevent HIV, but we know a lot about HIV and there's continued research on it, but there is a retrovirus that enters the bloodstream and binds to the T helper cells. It basically hijacks those host cells. It uses reverse transcriptase to convert the RNA into DNA so that it can replicate all of those bad cells and all of those virus cells, all of those HIV infected viral cells. So it basically gains access and then just multiplies and spreads. And again, it's like an HIV viral factory where it can produce billions of viral or virus particles daily. So without treatment, death due to other opportunistic infections, bacterial, viral, or fungal, will occur. And we will be talking about some of those common opportunistic infections that can happen to HIV-infected individuals and or persons with an AIDS diagnosis. I especially like this Creative Memories notebook slide that really goes through the signs and symptoms and clinical manifestations that you might see with an AIDS diagnosis or an HIV-infected person. We'll talk a bit more about the early HIV infections where a lot of patients don't really have a lot of symptoms other than like maybe some flu-like symptoms. But immunologically, the white count will continue to go down, and again, that CD4 helper 4 T cell count will be less than 200. That will put them at highest risk for some of the opportunistic infections that are listed on the right side. Integumentary-wise, there again are night sweats. They'll be more likely to poor wound healing, skin infections, more likely to develop infections. And again, they have a lot of gastrointestinal type symptoms, anorexia, nausea, vomiting, weight loss, and diarrhea. That can happen early, but it also continues as they extend into their AIDS diagnoses. Again, multiple systems are involved with HIV and AIDS, and we'll be discussing them more in detail. On the right side, you'll see the opportunistic infections that are very important to understand that are going to be more likely to happen with somebody with AIDS. So yeast infections, the fungal infections that are listed there, bacterial infections, other viral infections like herpes and varicella zoster, and then malignancies and cancers associated with AIDS, in particular Kaposi sarcoma and other lymphomas. So they also can develop what's called an AIDS dementia complex, where they have the dementia that's directly related to the HIV and AIDS diagnoses. I guess I skipped over that very first one, the protozoal infections, but pneumocystis carinii pneumonia is very, very common and occurs in many, many patients with an AIDS diagnosis. It's It's important to understand what sort of testing they're going to do for diagnosis of an HIV infection. They will do antibody testing via a blood sample. ELISA or EIA is the newer name of it, but enzyme-linked immunosorbent assay. That's basically the first test. It's inexpensive and it's very, very accurate. The patient's blood sample is mixed with an HIV grown in culture, and they can see if antibodies will bind to the patient's HIV antigens. HIV antibodies will bind to an HIV antigen if it's present, so that's how we know it's very accurate. Obviously, if there's no antibody that's binding, well, then there were no HIV antigens present. Now, the window period is really important because there's a time period when person's first infected and when viral replication occurs, but the immune system hasn't started quite yet making the antibodies. So a minimum of 3 to 12 weeks, but usually 3 to 6 months. Again, maybe up to a year. So either way, that's really, really crucial because we have to ask specific data about dates of exposure. We may need to retest or wait until the full window is over to make sure that we have absolute accurate testing. So they may do some early and get, say, a negative HIV, which is great news, but they'll want to make sure that all of that the testing didn't happen in that window where the patient was infected, but the body hadn't started making antibodies against that virus yet. So again, they will also want to absolutely confirm with a Western blot. If the ELISA is positive, they will move on to that. And another thing that's important that I just want to mention is approximately 20% of patients or persons do not know that they are HIV positive. So again, this is really, really important that we understand that HIV can occur at any age. It can occur in any diverse culture, ethnicity, Caucasian, older persons, young people, middle class, upper class, lower class. It basically is not limited to any age group or ethnic consideration or status, I guess, if you will. The Western blot then would be used to confirm the diagnosis of HIV. It detects the serum antibodies to 4 specific major HIV antigens, so positive if at least 2 of the major antibodies are detected. So they would do that ELISA first, and then they would confirm with a Western blot. They also have rapid HIV antibody testing. A pad is placed in the mouth between the gum and the cheek for approximately 2 minutes, and fluid is drawn into that pad and then placed into the solution. So this is rapid notification in about 20 minutes. There is a high accuracy rate, as you can see, 99%, but there would still need to be another confirmation. This is very similar to some of the home test kits that now you can buy at drugstores. They are not blood-based, rather they're transmucosal type secretions that are measured or that are assessed. Again, you would still need a Western blot for confirmation. When they're looking at HIV and AIDS, they will definitely be looking at other blood work and other labs to be assessing. And a patient may have lowered lymphocyte counts, which we call leukopenia. So lymphocyte counts are going to go down. The total WBC will go down and be less than 3,500. Remember, the normal WBC is 4,500 to 11,000. Lymphocytes will be low, less than 1,500. And again, remember that CD4 helper cell is going to be less than 200 for an AIDS diagnosis. They will have HIV sooner than that. They will have low T helper cell counts also, but once it gets to that less than 200, that's when the official end stage AIDS diagnosis occurs. Viral load testing. Just know that they will measure the presence of HIV viral RNA. They will measure this in the viral load will be present in 1 ml of blood. And so if they have a positive viral load, for example, it could be as few as 40 particles that were HIV infected per milliliter. It can be as high as 80,000 particles. So either way, the higher the viral load, the greater the risk of transmission. So again, this is helpful in monitoring disease progression, but also helpful in treatment progression and treatment effectiveness, and also helpful in knowing, your risk factor of passing that or transmitting that to somebody else is very high if the viral load is positive, and the higher the number, the more significant it is. Also, a patient can be HIV positive with an undetectable viral load if we're in that certain window frame that we talked about, that they can still transmit the HIV to an uninfected partner. So it's really important to know with all of these that we have to get through that safe window to make sure that all of the data that we're collecting is accurate. I forgot to mention on the last slide with that viral load testing, this can be positive in as soon as 10 days after infection. So again, there is that window where they could be infected or not know that they were infected, where they wouldn't have a positive viral load. But again, it's a pretty quick turnaround where they could be positive for viral load, and again, as few as 40 particles per milliliter. As far as the absolute neutrophil count, we'll talk again about this here, but again, specifically with cancer treatment as well. The neutrophils, remember, are our first fighting white blood cells that are going to go to the site of inflammation, injury, infection, etc. And so the neutrophil count is listed there, that normal range. And remember, we can measure the absolute neutrophil count by looking at the percentage of the neutrophils multiplied by the percentage of the immature. It's really important to know how many immature neutrophils, the bands or the stabs, are present. We, of course, want more segmented mature cells to be present. But if the bone marrow is releasing immature cells because the segs are used up, then we would see that, and that would be reflected in the calculation for the absolute neutrophil count. So absolute neutrophil count from your perspective can be thought of as really determining the patient's real risk of infection. It represents the total number of fighting cells, the fighting white blood cells, the fighting neutrophils that are available. So again, risk is significant at less than 100 for absolute neutrophil count, high at less than 500, and almost certain if somebody had an ANC of less than 100. So especially if you're working in oncology, you will be very familiar with this. We will place somebody on neutropenic precautions, of course, if they have a low neutrophil count and or a low total white blood cell count as well. Neutropenia is defined as when those neutrophils are less than 2,000. So again, neutropenia, even before we get to that significant risk of infection less than 1,000, we typically would put somebody on protective isolation or what we call neutropenic precautions. So here you can see the HIV and AIDS CDC, Centers for Disease Control classification system. There are 4 stages, but Stage 1 is the HIV infection. This is confirmed. The T cell count still is greater than 500 at this point in time. There are no AIDS defining illnesses as far as criteria. Typically in Stage 1, a patient would be clinically asymptomatic, feels well, no symptoms, may not have any idea that they are HIV positive. In Stage 2, this is a confirmed HIV infection with a CD4 T cell count of 200 to 500 or 499. So remember, this is when it's less than 200, it's going to be an AIDS diagnosis. So the Stage 2 is right in the middle, 200 to 499. And at this point, illnesses may be more frequent due to decreased immunity. They may have more progressive weight loss and may start to experience some symptoms. Stage 3, AIDS, this is again confirmed with a CD4 T cell of less than 200, and they will definitely have systemic symptoms, fatigue, night sweats, skin lesions. Again, almost certain that they will develop opportunistic infections once that CD4 T cell count goes less than 200. HIV infection stage unknown, this is what the text refers to as stage 4. Again, this is confirmed HIV infection, but no information on the CD4 T cell count or AIDS defining illness. So they might classify it as a stage unknown. Hopefully they'll have good information and be able to really put it in stage 1, 2, or 3, however. Also really important to know is that there's an average of 8 to 10 years before major HIV complications would occur, before a lot of the time before they would be progressing to that AIDS diagnosis. So there can be a lot of good years of HIV infected person before they actually get really clinically sick. Viral set point is also a steady state of infection, kind of the balance between the amount of HIV in the body and the immune response. So some people kind of stay in that viral set point for a while, that again, the average of 8 to 10 years. We will now talk about the AIDS-defining illnesses, basically those opportunistic infections that develop, and most every body system has some infection or opportunistic problem that can develop with an AIDS diagnosis. Again, when that CD4 is less than 200, our body becomes highly immunocompromised. The guards are not really watching, and we don't have as many fighting cells. Typically that absolute neutrophil count would be low as well. So under the respiratory system, again, we don't have to know every single last detail about all of these, but if I were expecting to think of what might be on NCLEX, I would say that they might have a question about pneumocystic carinary pneumonia, and right away I would want to know that that was a respiratory condition and one that I know was when somebody's immune system was down. So even just recognizing the names, knowing that yeast infections of the bronchial tree, the trachea, the lungs can happen, knowing that there's more chance of tuberculosis, all of those would be really good to understand, or at least to relate to the respiratory system, and then also relate as an opportunistic infection to somebody whose immune system is down, such as with AIDS. And again, then from there, I think most of us could really think what might be some symptoms related to respiratory conditions, related to pneumonia. Well, I'm guessing, again, without looking in the book, without even telling you all the details about each of these, we can expect that the patient might probably be short of breath, have some dyspnea, a cough, chest pain, crackles or other abnormal lung sounds, reduced oxygen saturations, and basically just signs and symptoms of respiratory failure. So we could then again go to the next step and say what sorts of nursing interventions would be appropriate. So while we're learning this content, I really encourage you to be thinking about making the connections of the condition with the body system that it pertains, what sorts of signs and symptoms that you might expect, and then also what interventions would be appropriate. 80% of patients with AIDS will develop a pneumocystis carinii pneumonia, so it is very, very probable, and it can be up to a 60% mortality rate with it, so it can be very serious. Neurologically, 80% of patients with AIDS will have some sort of neurological involvement. There is a very high probability of the HIV encephalopathy and what we know as AIDS dementia complex. So many people will develop a dementia, confusion, other signs and symptoms related to the neurological symptom as a side effect or as a, I guess, consequence or complication of their AIDS illness. So as we just talked about, the AIDS-defining illnesses can affect the respiratory system and the neurological. Again, the neurological system, the brain cells become infected by the HIV virus, so they end up with a decline in cognitive, behavioral, and motor functions. They can have more slowed movements, ataxia, etc. Now we just kind of move on to the other body systems, and we think about the cancer, the oncology type conditions. Kaposi sarcoma is the most common HIV-related malignancy. This is associated with the herpes virus, and they end up with very specific cutaneous or skin brown, pink to purple lesions. They may be flat or raised, but they usually have some ecchymosis and edema around them too. They may also have some lymphedema to go along with it. Lymphoma is the second most common malignancy for somebody with AIDS, typically non-Hodgkin's lymphoma being the most common there. Again, I don't need to know every single last detail, but if somebody has cancer, they're going to be immunocompromised because of the malignancy that is further complicating their AIDS diagnoses. As far as GI, the GI tract is very susceptible to thrush or candida, fungal infections, right? That creamy, those white patches that they might have in their mouth. They might also have vaginal fungal infections. They might have fungal infections on the skin, especially if they have more adipose tissue and skin folds, so we want to be watching for that. Definitely are going to have significant weight loss, nausea, vomiting, anorexia. 50 to 90% of patients will have those typical first bullet items: anorexia, nausea, vomiting, and chronic diarrhea. So with that chronic diarrhea, again, malabsorption, weight loss, wasting syndrome, they definitely will have profound weight loss, greater than 10% of their baseline. Chronic diarrhea as defined by greater than 30 days in a row that they have diarrhea. They may look clinically sick, have that tissue wasting, look thin or lower than their ideal body weight. Again, if we think about interventions for those particular areas, if we think of thrush or candida in the mouth, we think of the nystatin, swish and swallow, that they would need the mouth rinses, oral cares that are, soft bristle toothbrushes or mouth swabs. Again, doing just some warm salt water, trying not to have anything acidic that would hurt, of course, if we had lesions in our mouth. So some of it's just more common sense. The other thing is Megace is a medication that can be given to increase appetite. And so a lot of people with anorexia and the weight loss, we can give a medication to kind of stimulate that appetite. We'll do the best we can on high calorie, high protein foods and more easily digestible foods such as low fat. And of course, antiemetics would be appropriate as well. Gynecological, again, a direct correlation with human papillomavirus or what we know as venereal warts, and an increased incidence of cervical cancer as well. Transmission of HIV and AIDS, as we know, is primarily from body fluids containing that HIV and or infected CD4 T lymphocytes. We have the infected T lymphocytes that then gains access to the infected person and then can be transferred via blood, seminal fluid, vaginal secretions, amniotic fluid, and breast milk. So any behavior resulting in a break of the skin mucosa increases the probability of HIV exposure. We know that the most AIDS cases in the United States are men who have same sex with men or either gender using injection drugs, but obviously those are not the only ways that we have transfer of the HIV virus. So safe sex, protection, or abstinence is really the best way, avoiding contaminated needles, obviously not sharing needles, and then universal precautions, of course, for healthcare workers, very, very important. Healthcare workers, of course, are exposed to blood, body fluid, etc. all of the time, but we hopefully are not actually exposed because we're using universal precautions and we're always wearing gloves when we are going to potentially come in contact with somebody's blood or body fluid. As far as the exposure risk, hepatitis B, a needle stick with hepatitis B infected patient will result in a 6 to 30% chance of infection, where HIV, it's like a 0.23% of a needle stick infected. So HIV is going to be more so transferred via unsafe sexual intercourse and mucosa entrance that way. So I'm not minimizing, obviously, the risk. I'm just letting you know that hepatitis B is really where the HIV or the infected needle infections, needle stick complications are coming for healthcare workers, much more anyway than HIV, I guess, is what I wanted to highlight. The highest rates of new cases are adults of color, African American and Hispanic. And again, this is all based on research. This is just what we know. Certainly all ethnic groups are, and all genders and all ages are still at risk and need to know all of the prevention of transmission stuff. HIV is more easily transmitted also from an infected male to an uninfected female. Again, the infected body fluid will come in contact with the mucous membrane and in a non-intact skin. So the vagina has a high surface area versus, say, the penis. So that's why the women can get infected much more easily with the exposure and trauma to that large mucous membrane area. As far as a little bit on pregnancy, effect of HIV on pregnancy outcomes, there is the higher probability of premature delivery and low birth weight. And again, there's a possibility of transmitting of disease to the infant. So if in an HIV infected mother, antiretroviral medications during pregnancy would reduce the risk of transmitting that to the infant. The public health departments do require reporting of STIs, sexually transmitted infections, or STDs, but they may identify and notify sexual partners if requested. So again, especially if you're working in the public health arena, you're going to be more familiar with the reporting process of confirmed patients, of confirmed STIs of HIV, AIDS, chlamydia, gonorrhea, syphilis, Cancroid hepatitis A, B, and C. Do not need to consent to report from patient, but must disclose that the disease has been reported to the Minnesota Department of Health. So we don't need a consent saying that we can report it or will report it, because we are mandated reporters to the Minnesota Department of Health. Priority nursing diagnoses for HIV/AIDS really depends on what the stem of the question would be talking about. If it was talking about something with a, let's say, the pneumonia complication, well then certainly we might be thinking of something with gas exchange or airway clearance, obviously. If it's a respiratory type opportunistic infection, there's a high likelihood that they're having respiratory related symptoms or impaired gas exchange or ineffective airway clearance. Obviously, all patients with an immunosuppression such as HIV/AIDS will have risk for infection related to their decrease in T cells and the immunosuppression of the disease itself. Otherwise, as we know, as you look back to the body systems of complications, the chronic diarrhea, the weight loss, the malnutrition because of the low appetite, the wasting syndrome, all of that would place emphasis on imbalanced nutrition, less than body requirements. And again, if we think of ABCs, we also have to then think about Maslow's next. So that could be high up on the priority. So again, I can't really say exactly for sure. There's plenty of psychosocial ones that would be appropriate. Again, it's not always black and white. It would really depend on the information you were giving in the stem of a question to help you determine exactly what would be appropriate. But certainly we'll go by ABCs, safety, Maslow's, and look at those things first. Treatment of HIV and AIDS is going to include many things, a lot of education about reducing the risk of infection, all of those things, keeping them safe. If they are immunocompromised, if any patient's immunocompromised for whatever reason, we're going to teach them about hand hygiene and making sure that they are avoiding interaction with others that have actively infection, cold, etc., people that may be contagious to them. We certainly are going to treat all of their existing symptoms, infections, malignancies, some of which I gave some examples. For example, if they have a fungal infection or if they have diarrhea, whatever it may be, antiemetics, anti-infectives that kind of help with the disease complications and symptoms that they may be experiencing. Hydration and nutrition is always going to be a good priority, because we do know that they will have wasting syndrome over time, especially as they get later in their disease process. And monitoring weight and assessing for signs and symptoms of dehydration would be very appropriate. We definitely would invite the dietitian to consult with this patient to see if they can help with any suggestions, look at the patient's financial means for food, their favorites, their likes, dislikes, and hopefully try to come up with a plan for a high calorie supplementation on protein. Maybe more small frequent meals might be appropriate. Controlling nausea and vomiting, maybe they're taking some prophylactic antiemetics so that they reduce their nausea and may be able to eat a little bit more. The megestrol acetate, this is the Megase that I mentioned before. This particular medication actually increases the appetite. It doesn't necessarily control the nausea, vomiting, but it does increase and stimulate appetite. So sometimes they'll use that in combination even with an antiemetic. And then just watching their labs. Of course, their serum albumin, which we know is the same value as potassium, 3.5 to 5. We might expect patients with HIV and AIDS, again, if they're showing that wasting and showing protein catabolism, we are going to expect that that serum albumin would be low. Neutropenic precautions, also known as protective isolation. We've covered this in the cardiac hematology area. This is just an absolutely important need-to-know type item. This is all of the things from as simple as hand washing to private rooms to not having people visiting that are sick to wearing a mask to no fresh fruits and salads and vegetables. So a low microbial diet. We don't want to have any of those things that have fresh live microbes on them. Again, staying hydrated. Making sure that we don't have stagnant water in the room, such as in plants and in vases and things. Again, you see a lot of the obvious, but just making sure that we remember. Also remember, as the RN charge nurse, these are always good questions in making an assignment. Who would you assign? you know, the patient that's caring, or the nurse is caring for a patient in neutropenic precautions, who would be another patient that would be appropriate to give to that nurse? And maybe you have to choose from a list of patients. We would not want to give them that same nurse somebody that has like a patient with pneumonia, somebody who's actually highly contagious or could transfer that infection. Now, granted, the nurse is still supposed to be doing their due diligence of standard precautions and hand washing between rooms and not doing any of that spreading, but we still have to make a good judgment on the room assignment and also the nurse assignment. So a lot of teaching and emotional support with patients with HIV and AIDS. There is just a lot of unknowns. We don't really have good data of actually for sure for everybody how long they're going to stay in the various states. Some people can have many, many years of HIV infection but not having any clinical illness, which is wonderful. And some will progress more quickly through that. So again, all of that is very important. Also, just the feelings of guilt. Again, if it was a risk factor that they could have prevented themselves in getting HIV, that also comes into play for not only the HIV infected individual, but also friends and family members that also may want to blame them for their illness. So lots going on with patients with HIV and AIDS. Of course, there's lots of ongoing research for HIV and AIDS. We don't have a cure as of now, but we do have many medications, antiviral medications that will help with treatment to slow the progression and try to block and slow some of that viral replication. So CART, C-A-R-T, combination antiretroviral therapy, this was previously known as HART, highly active antiretroviral therapy. So if you see CART or you see HART, this is basically a combination of multiple drugs, medications that have been approved for treatment of HIV. Again, when you look at your table in your textbook, there's a lot of them, you will see that basically the action of all of them, while it's very detailed and scientific, the bottom line, they basically say that one way or another, they're going to block the viral replication. So that's really the importance, because this virus is just replicating and replicating so fast in the body that we have to stop and we have to slow down that replication. HIV medications, antiretroviral medications are typically very costly, and they certainly do have some serious side effects. In particular, the most serious and significant is bone marrow suppression. So when I say bone marrow suppression, hopefully you can think of reduced red blood cells, reduced white blood cells, reduced platelets. They also can increase cholesterol and triglycerides and have some cardiovascular effects with earlier onset atherosclerosis and also cardiomyopathy. So those are some of the effects that obviously would be negative, but I mean, there's no choice. They need to be on the medications. Again, you will see some of the drug names there. A lot of them ending in DINE or BINE, so hopefully you can recognize those names if you were to see them. Post-exposure prophylaxis for us as the healthcare workers is very important to know your facility policy, your facility structure for reporting, etc. So the very first thing, if you were to have be exposed and be infected, let's say that you had a needle stick that was obviously had been in the patient, a needle stick following an injection, you would first wash your area, in this case your hands. You'd wash your hands very thoroughly with soap and water, and then you would report to the emergency room immediately. Of course, you would tell your charge nurse. The patient that is identified, so in this case the patient would be known and identified, would have a blood test run on them. If it's an unidentified source, well then we don't have a way to do that. So for example, if it was in linens, if there was a needle that got in a linen bag and somebody gets a needle stick on the other end in laundry, they have no idea where that came from. Obviously, I hope that never happens. We should always be very, very careful. We need to dispose of our needles properly in the sharps container ASAP. You know, we don't mess around with those sorts of things, but obviously if the source is identified, that patient will be tested. Patients do sign a consent on admission for their care and treatment that they would be tested if there was an incident like this. So it's not like we need to get another, assessment or consent from that patient. So our job is to wash our hands with soap and water, to report to the emergency room. They'll do some baseline testing. They'll obviously get the lab back on the source of the patient, and if for some reason they were HIV infected or hepatitis infected, they would start prophylactic medication within 2 hours of exposure ideally. And then there's quite a regimen of medication, but usually up to a 4-week time period. They will do, of course, follow-up testing in 1 month, 3 months, 6 months, and 1 year. So there is extensive testing and hopefully reassurance for that healthcare worker, and hopefully good results where the tests will continue to come back negative. Prevention is basically very important, as we can imagine, and education, community education, education in our middle schools, high schools, etc., to make sure everybody understands safe sex, abstinence, etc. Healthcare worker prevention, of course, avoiding contaminated needles, no recapping of needles. We've gone to needleless systems for a lot of things, way more than ever was, and of course the use of standard precautions for all patients and for every single procedure where there may be risk to exposure to blood and body fluid. So we will now move into talking about cancer. During our lifespan, our body's tissues normally experience rapid growth or activity, which we call proliferative patterns. Cancer is is from a defect in that cellular proliferation. So the cell growth, goes just crazy and doesn't really follow the physiological demand, and it doesn't follow the physiological pattern, size, shape of its host cell, if you will. So it's a disease process where you see there's abnormal cells transformed, and then those abnormal cells basically proliferate, which they grow and they multiply and they clone themselves, and now we're making a bunch of copies of these abnormal cells. Metastasis, of course, is when those abnormal cells gain access to the lymph and blood vessel and then therefore other organs. So ideally, if we do have cancer, we'd like it to be contained to one area, to one organ, to one section of a area, like a section of a bowel or stomach. And if it's all contained, then a lot of the surgical procedures can be very successful because we can remove surgically all of that area. If it has not spread to the lymph and blood, obviously much more successful of treatment. I wanted to highlight a few of the words because we'll read in our physicians' H&Ps and notes, they'll talk about hyperplasia and metaplasia and dysplasia. And again, not that we have to know every detail and memorize these definitions, but as you can see, they have to do with an increase in number of cells of that tissue, conversion of the mature cells into another type of cell, and with dysplasia, it's just bizarre cell growth, and they differ in size, shape, and arrangement. So if somebody has dysplasia, cervical cell dysplasia, there's been an abnormal growth of those cervical cells in that target tissue and organ. So again, if you see any of those words, plasia, that basically means a form of development or proliferative patterns. And again, it depends on if those cells are malignant or benign, but if they are malignant, meaning they are cancerous, we don't want to see dysplasia of malignant cells, obviously. So malignant neoplasm, for example, would be what they call cancer cells, and those malignant neoplasms will replicate. And here's the last two that end in plasia, anaplasia. Ana is backward. Backward for formation is what that word stands for. And so again, they vary in size and shape, and the degree of anaplasia usually determines the malignancy potential. So under the cell, and even when they look and have done surgical, doctors and surgeons know what the tissues are normally supposed to look like. So they can basically see, and obviously they're not confirming anything when they do the surgery because they have to wait for the official pathology, but they can really tell that there's a lot of cells that look different than the normal cell is supposed to look. So they can already have a pretty good idea even when they do a surgery, for example. Neoplasia, again, malignant neoplasm. Think about malignant neoplasm. We know that's malignant, that is cancerous, abnormal growth, neoplasms that are not following the pathological demand or pattern. This slide is showing you what normal cell division is supposed to look like, and the body, of course, is made up of many types of cells, and these cells grow and divide in a controlled way to produce more cells as they are needed to keep the body healthy. When the cells become old or damaged, they die and are replaced with new cells. However, sometimes this orderly process goes wrong, and the genetic material, the DNA of a cell, can become damaged or changed, producing these mutations that affect the normal cell growth and division. When this happens, cells do not die when they should, and new cells form when the body does not need them. These extra cells can form a mass of tissue that we call a tumor. This slide just reviews the differences between the benign versus malignant neoplasm. Neoplasm is an abnormal mass of tissue as a result of neoplasia, which we just talked about it. I always remembered benign tumors as benign, be not, meaning they are not cancerous. Benign is well differentiated. The cells look a lot like their normal cell or tissue of origin. They're very slow growing. They don't spread by metastasis, and they are usually encapsulated. Again, does not usually cause tissue destruction or death. So like I said, benign, be not. Malignant are undifferentiated, so they bear little resemblance to their normal cells or the cells of the tissue of origin. They have a variable growth rate, variable rate at which they are multiplying and spreading. They do gain access to the blood and lymphatic channels, so they do get outside of their edge and infiltrate the periphery and gain metastasis. So again, these do cause tissue damage and death unless growth can be controlled. So malignant neoplasms, we call those the cancer cells. Again, all cancer cells are going to share some common cellular characteristics, special proteins, nuclei, chromosomal abnormalities, and the rate at which they replicate themselves and grow does vary. But again, malignant cells also, because they do contain some of the same proteins, we have some measures in which we can measure the tumor-specific antigen. So we'll talk about that with measuring CEA, PSA, like CA-125 for ovarian. There's all sorts of different blood tests that are somewhat helpful in looking at how many of those malignant cells contain that same protein or that tumor-specific antigen. And so this is helpful for not only diagnoses, but especially helpful for seeing if our treatment is working. And just so you know, a tumor, we usually can't detect tumors until there's 30 million cells in it. So there's a lot of replication of that malignant tissue or malignant cell before we actually have a cancer that is noticeable or notable, that we can see it or that we can actually detect it. Metastatic mechanisms of cancer occur via 3 different ways. So lymphatic spread, this is when that tumor is transported through the lymphatic circulation. So for example, it usually gains access to the lymph channel that is closest to its tissue of origin. So if a person has breast cancer, for example, it will gain access via the axillary nodes. That's why they typically do a sentinel node biopsy, where they will remove the breast tissue or part of it, or the biopsy or whatever is necessary for that condition, and then they will remove as many nodes as possible until they have a negative. They're going to basically check to see if the closest node, the sentinel node, which is the closest to that tissue, is negative. If for some reason it's not negative, they'll continue to move down and remove more nodes until they do have a clean node. Malignant cells can also transfer via hematogenesis spread, and this is where they are disseminated or travel through and directly into the bloodstream. So this is directly related to the vascularity of tumors. If tumors are more vascular, they're going to have a better chance of living and growing and spreading in the bloodstream. Angiogenesis is the ability to develop new blood vessels, and this is where the host tissue releases proteins that stimulate formation of a new blood vessel, and it helps those malignant cells obtain the necessary nutrients and oxygen that they need. And so that those tumorous cells, host tissues, are able to live independently. They can supply that tumor with their own blood supply. So of course that is very dangerous, where the cells themselves can just provide oxygen and nutrients and continue to live inside the body and replicate itself all on its own, separate from our lymph and separate from our bloodstream. Carcinogenesis is basically the initiation of cancer formation. So again, malignant transformation. That would be another way to look at it. And in this slide, we're just talking about, what are some known carcinogens? What are some known risk factors, known chemicals, or things that could potentially cause the initiation of cancer formation, which is the carcinogenesis? So viruses and bacteria, for example, the herpes virus will have a higher risk factor of cervical cancer. We know the HIV we just talked about would have a higher chance of the initiation of Kaposi sarcoma, which is the most common form of cancer for HIV infected. H. pylori bacteria would be another example, H. pylori, and we will talk about this but in GI, but this lends itself to a higher risk of developing gastric cancer. So there are different viruses and bacteria that we know can potentially associate with cancer. Another one would be hepatitis B virus. Again, increased incidence of liver cancer. Immunodeficiencies, just being immunodeficient in the first place, puts the weakened immune system at a greater chance of developing cancer and allowing foreign materials to gain access to the body. Physical agents, of course, sun. We'll talk about sun exposure with malignancies of the skin and with melanoma. Chronic irritation, inflammation, lots of different things that can be included there. Could be wind exposure, certainly could be other forms of environmental physical agents as well. Chemical agents, well, some of these are very obvious: tobacco, nicotine, whether it's smokeless or smoking, pesticides, people that are working in those type of occupational areas, or asbestos. So those agents do increase risk of the formation of cancers. Radiation exposure, different medications, can also increase risk. Genetic predisposition is huge. There are many cancers that have a very solid, but just really definitive genetic makeup and genetic background, such as breast cancer. So many times, and if the mom has breast cancer, the daughters, their daughters, and you can just see it all across the lines of aunts and grandmas, etc. So not every cancer is that way, but many of them do have at least some percentage of a genetic predisposition. Dietary factors, we know that nitrates, any of the additives, and then higher fat foods, red meats, etc., can increase the rates of cancer. And then hormonal agents, in particular oral contraceptives, especially if that patient is also smoking. But oral contraceptives in general, those hormone replacements, can increase the incidence of breast, endometrial cancers. But interestingly enough, birth control decreases the risk of ovarian cancer. We also know that obesity is not on this list, but obesity increases cancer risk. And we definitely know that increased fruits and vegetables will decrease cancer risks. And in some countries where they're very healthy eaters and they don't have fats and alcohol and salt cured and smoked meats and nitrates and processed foods, they have very low rates of cancer. This slide demonstrates the estimated new cancer cases in the United States for 2018. So basically, this is the leading causes of cancer, and they update this every couple years. It really hasn't changed over many years. Over the last 10-15 years, it's pretty much held the same. Breast and prostate for both male and female are the leading causes as far as cases, number of cases. Lung and bronchus as number 2, and colorectal as number 3. Those have been first, second, and third, like I said, for many years. So again, when we start to look at cancer screening, cancer prevention, educating our patients, it's super important that they understand what they need to do, what tests, what self-exams they can do for themselves in early detection of these leading causes of cancer. This was also the update. Now this is cancer death, so the incidence by cancer death, and you will see that it's still the same three, but those that die from these cancers is different than the frequency of the cancer. So now lung and bronchus is number 1 as far as deaths related to that cancer, and then the prostate, breast is number 2, and then colorectal remains number 3. Number 3 for incidence and number 3 for the rates by death. And you see pancreas as number 4. And I'm going to show you the next slide, which is a 2020 update that I found that does have pancreas moving into that 3rd spot by gender for cancer deaths. So this is the newest data for 2020, and on the left you can see the estimated new cases, which is still, again, I like the other slide, that's why I kept it there for by male and female, but you'll see the breast, lung, bronchus, prostate, and colorectal, and then melanoma next in line as far as the new cases as of 2020. But here's the one by death. Lung and bronchus is still number 1. Colorectal actually moved up to number 2, pancreas 3, and then breast and prostate 4 and 5. So either way, I mean, that you understand that these kind of top cancer diagnoses are the leading cases and the leading causes of death for that type of cancer is really, really important that you understand that. I was unable to find the newest update on this, although I do believe that they typically have been the same for lots of years, so I doubt that there's any change. But this is the top 3 causes of cancer death in children and adolescents. So it's quite different what we see for cancer incidence and death for that age group. You will see more of the blood cancers, leukemia, and then you see the brain tumors and brain cancers as the top 2. I think it's important that we do just a very quick review of the American Cancer Society recommendations for screening for the different various most common types of cancer. I know that we've discussed them in each of their given units, but this is a good time to make sure that we remember them. So for breast cancer screening guidelines, basically after the age of 40, they recommend a professional breast exam and then a mammogram annually. So, and of course, they recommend a self-breast exam to be done monthly. So those would be the recommendations for breast cancer. Of course, they can start earlier than 40 if they do have a significant family history with breast cancer. Then they would be starting these screenings prior to the age of 40.